Dr. Lin, whenever you're ready.
All right, so let's get started. I am Dr. Lin. I'm one of the glaucoma specialists here. I'm also the Director of Medical Education here at the Gavin Herbert Eye Institute. Very happy to be doing this community talk. I would have wished that I can see everybody's face, but I know that if I were you, I would probably like to hiding anonymity and just enjoy dinner, have a little sip of red wine, and just listen on. But we will give you opportunity to type your questions, and we will try to address those questions at the very end. So I thought I would just talk about what I do on a day-to-day basis, as well as what my research is on, which is glaucoma. So it's hard to summarize glaucoma in a 30-minute span of time. So what I want to do is I compile a list of 10 top most frequently asked questions from patients, and in doing so, I wish I will be able to kind of give you a gentle introduction to what glaucoma is and what we can do about it. And in terms of disclosure, I'm a research consultant for J&J and NVIDIA, and I have research funding support from the American Glaucoma Society and the RPB. So here are the questions. So we'll start out talking about what is glaucoma and what causes glaucoma, how is glaucoma diagnosed, and what is considered quote unquote normal eye pressure, and how is glaucoma treated. And also a very commonly asked question, which is, why is my vision worsening when my eye doctors keep saying everything looks okay? And then we'll get into whether there are supplements, diets, or exercises that may help with glaucoma. And the most dreaded questions, am I going to be blind? And then also we'll talk a little bit about people whose eye pressure is always been very low, and yet they were told that their glaucoma is progressing. So what's up with that? And finally, we'll wrap it up with what's coming down the research pipeline, some of the more recent developments and what is in the near horizon. So first, what is glaucoma? And here is actually pretty close to a textbook definition that you will find in any standard textbook. It is defined as a chronic condition in which the optic nerve loses its volume, and after it loses its volume, it's going to start to slowly lose its function. And it is most commonly because of this happens most commonly because of its inability to cope with the pressure within the eyeball. Now, the loss of the optic nerve volume eventually will lead to a loss of peripheral vision. And at that point, if nothing is still being done, eventually it's going to affect the central vision as well. So this is more of a classic sort of progression of events. In the beginning, most patients are not aware that they have glaucoma, and they start to lose peripheral vision, which most people are not aware of. And then eventually time goes on and family members starting to realize, why is Uncle Joe having to keep turning his head in order to see if somebody's sitting next to him or not, and finally realizing that Uncle Joe has no peripheral vision left. And finally, the last step, the last part of the vision to go away is the central vision. And hence, some people call glaucoma the silent killer because it does not give you any symptoms. In most forms of glaucoma, you do not have pain. In certain subtypes of glaucoma, you will have pain, but the vast majority of glaucoma patients do not have pain. And patients do not have any vision changes until the very late stage. Let's review the eye anatomy a little bit. What is optic nerve? Optic nerve, you can consider that as a cable that connects your eyeball and it sends the information towards the back of the brain. It connects to the eyeball and it acts as a conduit where all the sensors coming from the retina all converging to that point, about 1.5 million fibers, then go into that tunnel and then head straight to the brain. So it is a very important structure. It is basically where all the sensors just converge together. And in glaucoma, that optic nerve is susceptible to the pressure within the eye. And over time, when the pressure in the eye is a little elevated, it's starting to push onto the optic nerve, and the optic nerve starting to lose its volume. And once it loses about 30 to 40% of its volume, that's where peripheral vision is starting to go away. This is what normal vision looks like. This is what patients with advanced glaucoma may experience their vision. Once again, it's important to know that straight ahead, you can still see what you're looking at, but what the patient may not be aware of is the loss of the side peripheral vision. So what I often do is I will tell a patient, this is very similar to losing about $20 a month on your bank account. Obviously, it depends on how much money you have in the bank account, but for the most part, if you lose $20 a month or even $10 a month, you're not going to be immediately aware that your bank account balance is going down. But after a while, that $10, $20 a month is going to start to accumulate, and it's going to start add up the effect. And then you may realize it down the road, but most people will not realize it right away that something is happening because you simply don't pay much attention, again, in this case, to your peripheral vision. So what causes glaucoma? The spotlight is really on the eye pressure because that is the only treatable cause of glaucoma. So let me say this again. Increase in the eye pressure is not the only cause of glaucoma. However, every therapy, every medication, laser, surgery, anything that we do is single-handedly focusing on reducing the eye pressure because that is the only variable that we can treat. We are starting to realize that there are pressure-independent causes that can cause glaucoma. And I won't get into too much of that because much of that is still in the realm of research. And also the sort of the big picture of that part of the research is that we currently still do not have anything that's FDA approved to treat these pressure-independent causes for glaucoma. So how exactly do we calculate eye pressure? It's essentially a plumbing problem. So eye pressure, just think of that as how much fluid is being produced in the eye minus how much fluid is exiting the eye. If there is an imbalance in how much is being produced and how much is being drained away, then you're going to have a pressure problem. Just think of input, output. If you eat too much and you're not putting out as much, you're going to start gaining weight. And in the case of an eye, the pressure is going to start going up. The opposite situation, if you're not putting in enough and yet you're draining away a lot, obviously the pressure is going to go down. For literally 99% of glaucoma, the problem is not at the production of the fluid part. The problem is all happening at where the fluid is exiting the eye. In fact, almost everybody with glaucoma, the problem is at the drainage side, the internal drain that drains away the fluid in the eye. Now, this drain is not the same thing as what drains your tear. Your tears are external to the eyeball. What we're talking about here is the fluid that's within your eye, something that we call the aqueous fluid. And that's completely separated from the outside part of the eye, and it has its own internal system. So if you look at the picture here on the bottom right corner, the wavy yellow arrow indicates the path where the aqueous fluid travels within the eye. It comes from sort of the right next to the lens that you see there, and then it is produced in this little tissue called the ciliary body. The fluid gets produced here, and eventually it leaves the eye in the front chamber, what we call the anterior chamber of the eye, which is formed between the cornea and your iris. And the aqueous fluid will exit here through the drainage angle. So people with glaucoma, they're not producing too much fluid. The problem they have is they're not draining enough at where the drainage angle is. So either their drainage pipes are not big enough, or the drainage pipes have a lot of obstructions. So why is that? So what causes glaucoma? For basically most forms of glaucoma, the problem comes down to the size, density, and porosity of the drainage system. And you don't really have much control in terms of the size and the density and the diameter of these internal drains. In fact, that is the reason why glaucoma is highly hereditary, because just like your height and your weight and your body features, a large degree of all these features are passed on through and written in your genetic code. So the fact that genetics plays a big role in glaucoma, you can interpret that from the angle of that's what determines the size and density and basically the physical feature of your plumbing system inside of the eye. And I highlight the word genetics in red. That's because that is really the majority of the causes at the molecular level. That's what's happening. All the other items on this list here, they can sometimes cause glaucoma, but they are more on the rare side. Of course, in our university clinic, we do see a lot of causes of glaucoma from all these other items here, but they're not, if you have to take a guess, it's usually not one of these. So let's go over some of these lists here. Pigments in the eyes. There is a type of glaucoma called pigmentary glaucoma, in which the eyes, inside of the eye, there continue to be shedding of the pigments that reside in the back part of the iris. And this type of glaucoma, there is a very strong family history as well. And these pigments get released and they don't have anywhere else to go but go to the drain and start clogging up the drain, causing pressure problem. Trauma is a very important cause. If you play baseball as a kid and got hit with a baseball towards the eye, that can certainly damage those internal drainage system that I showed you earlier. Being on steroid, steroid is notorious for raising the eye pressure, and especially nasal spray. So that's something that I always ask my patients, are you on steroid? Were you on steroid? Eye surgery, that is also a very big category. Any eye surgery that takes place inside of the eyeball, including cataract surgery, or even just on the surface of the eyeball, can all have the potential to cause glaucoma. Just think of your house. If you have an electrician coming to fix certain things, can the plumbing system be affected? Absolutely. And your eye is a very small space. It is hard to be fixing one thing without affecting other parts of the eye. And that is kind of a 30,000 feet view of why doing eye surgery sometimes can then lead to pressure issues. Uncontrolled diabetes is another very common cause, and also very low blood pressure can also cause a glaucoma-like picture. So how is glaucoma diagnosed? Well, again, we focus a lot on the eye pressure because, again, that is the only thing that we can treat. So we need to find out what the eye pressure is. And we also need to do a comprehensive eye exam, looking from the front to the back part of the eye, looking for any other obvious reason for the pressure to go up. And some of these reasons could be that there is unusual anatomy, or there may be a little mass or lesion or tumor obstructing where the drainage system is, things of those nature, trying to identify things that may explain why the pressure is up. And also we'll take a look at the anatomy of the optic nerve, how the optic nerves look, how thick is the optic nerve. And then we also do a functional test, which is what the peripheral vision test is. The gold standard for checking the eye pressure is through what's called an applanation tip, which is the picture that I showed here on the right bottom here. It involves touching the eyeball. This is the most accurate way of checking the eye pressure. I'm sure you're all aware that there are other ways to check the eye pressure, including an ear puff or tonal pen, or even there are now home eye care kits available for you to kind of check on your own eye pressure. None of that has been shown to be as accurate as the applanation tip. So here is an example of a peripheral vision test. Many of you may have seen this before. We had to put your head in there and different light dots will go on. You're supposed to look straight ahead. It will not be much of a peripheral vision test if you cannot look straight ahead and you just keep chasing after the dots. So this test is meant to see how, to really get down to the grainy details of how good your peripheral vision is. And it puts out a picture to represent how your peripheral vision looks. And this is pretty much what we consider as a normal peripheral vision. There is a little blind spot, a little dark spot that you see there. That's a physiologic blind spot. Everybody should have that. The other test that we administer to the patient is the optic nerve scan. This is basically a way using a laser technology to quantify how thick the actual optic nerve is. It's not enough for us to just look at it head on. We wouldn't be able to tell to the micron level how thick the nerve is. And this machine here allows us to analyze what the average thickness of the optic nerve is, and pictorial, and it shows it in picture, and it can also track whether your optic nerve is getting thinner and thinner over time. So we're not so much comparing any patient against all the other patients. We're very much in when we say glaucoma follow-up, we're following up how that particular patient's optic nerve is looking over time. So we're just comparing you with you. We're not really comparing you with everyone else. So that leads me to the next question, which is, what is the normal eye pressure? So there is, experts don't even have a consensus on what exactly defines the eye pressure, because the question itself is actually not a very scientific one, because there is no such thing as what's the normal eye pressure. Just like heights, there is no such thing as a normal height. When it gets too short or too tall, then we start to get a sense of, oh, that's not kind of normal. But there is a lot of subjectivity to it, and eye pressure really varies widely. And the problem with trying to define a normal eye pressure that works for everyone is that we really don't know how much pressure each individual eye can take. For example, your right eye may be able to soak up a different amount of pressure compared to your left eye. And by looking into the eye, we're not going to be able to identify a sentence that says this particular eyeball can only tolerate a pressure up to X. I mean, if that's how we were made, then that will make our job very easy. Unfortunately, when I look into your eye, I cannot identify a line like that. So we had to figure out what is a good pressure for this eye. So again, that goes into the next item here, which is it is unknown how susceptible each optic nerve is to the effect of pressure. The population range for the eye pressure is between 7 and 22. So we know that this range essentially encompasses about 98% of the population spread of the pressure, with an average of 18 and a standard deviation of 3. You may have gone to eye doctors in the past, and the doctors will basically say your pressure needs to be 21 or under, which is it's a concept that has been proven a little obsolete since about early 2000s. The reason that 21 kind of comes about is the average plus one standard deviation of 3. So 18 plus 3, that's 21. So it used to be that this 21, the number 21, was used to conveniently define what is normal versus what is abnormal. Unfortunately, reality is not as simple as that. Just like Newtonian mechanics cannot fully define how the physical world interacts, and then we need a quantum mechanics. Everything is reality often turns out to be a little more complicated. So we've learned that if we just arbitrarily set 21 as the target, we're going to be overdiagnosing about 30% of the people and miss out about 50% of the people. So this 21 threshold really does not apply. And the reason why it doesn't apply is every eyeball simply tolerates different amount of pressure. So we cannot cast a wide net and say just use 21. Otherwise, you probably don't even need to see your doctor. We can just set up stands where you can just get your pressure checked. So that's really not the case. Instead, glaucoma specialists use what's called a target IOP. IOP stands for intraocular pressure. And in many cases, it takes many months of observation to really test, to define a target IOP, because you simply don't know if this person is going to be doing fine in this particular pressure, unless you let that person kind of run in that particular pressure for a while and see if the nerve continues to thin out. And that really is the forefront of what the field is heading towards. Is more an individualized treatment goal, rather than just say, okay, let's just get your pressure under 18 or under 15. We kind of need to look at where your pressure has been and where you are right now and how your testing is looking, and together kind of come up with a number. And target pressure can be different between the two eyes. So how is glaucoma treated? We almost always start out with medications, medication eye drops, and there are generally up to about 4 different types of eye drops. And I say types, the types refer to how they work, their pharmacologic targets. Most of them will make your eye to produce less fluid. So remember what I said earlier, eye pressure is basically how much fluid is being produced minus how much is being drained out. So if you reduce the amount of production, then you can lower the pressure that way. And that's actually how most of the eye drops works. There is there are a couple of new glaucoma medications that were recently approved by the FDA that work through an entirely different mechanism. It inhibits a very interesting protein target called the rho kinase. Now that is a very new medication. Some of you may have heard of that. So that we're very excited to have that medication added to our typical armamentarium to treat glaucoma. But generally, we start out with medication. And if these medications are not enough to lower the pressure, then we consider additional steps, such as laser or surgery. Now, the one thing that's important to keep in mind about doing these eye drop, medication eye drop, is that they will not help you to improve your vision. Your optic nerve is as old as you have been. Generally speaking, they also age too. So what these eye drops are doing is to trying to slow down that deterioration process. Just say, no matter how you remodel your house, you're not going to make your house brand new unless you just tear them down and build a new one. But since we cannot just take out your optic nerve and then swap in with a new one, what we're trying to do here is trying to preserve its function as much as possible. So when you're operating under a preservation mode, by default, you simply cannot exceed where you are right now. And our goal is always to trying to maintain the optic nerve function as its status quo. So I always tell my patient, no news is good news. And the next is laser. Laser is a very commonly, it's a very safe option to trying to lower the pressure as well. And then there's surgeries. Cataract surgery oftentimes can also lower the pressure. And then there are several procedures that are lumped into what's called minimally invasive glaucoma surgeries. And finally, there are the traditional glaucoma surgeries, which include trabeculectomy and glaucoma tube shunts. The higher the risk of the surgery, the greater the return and the reduction of the pressure. So it works kind of just like investments. The lower the risk, lower the return. The higher the risk, the higher the return. And the same thing can be said about glaucoma surgeries. The safer the surgery, generally, the less pressure reduction you tend to see. The higher the risk, you may potentially see a large drop of the eye pressure. Here is just some pictures showing trabeculectomy. Trabeculectomy is essentially where we create an opening on the wall of the eye to let the fluid drains out. And then we covered it up so the fluid will not just keep leaking out and you will feel like you're tearing. It's not that. We just make the opening such that the fluid will directly go towards the back of the eye. So everything is still covered by the top layer of the eye called the conjunctiva. Another traditional surgery is called the glaucoma implants, where we actually put a hardware right above the walls of the eye with a tube that then eventually we direct it into the eye to help drain the fluid. And this hardware will help direct the fluid towards the back of the eye. I do this procedures a lot. It's called trabectome. Trabectome is one of those minimally invasive glaucoma surgery that we often do at the same time as cataract surgery. What it does is, you can see in the picture here on the right bottom corner here, we place a trabectome instrument tip into the eye, and it simply removes the top layer of the drain. And in a sense, you can think of that as just cleaning the drainage system by getting rid of all the junks and all the gunks that have accumulated there over the years. So it removes that, use electrocautery, and it also suction it out using an irrigation aspiration port. There are also eye stents. Many of you may have eye stents placed at the same time as your cataract surgery. That is also another way to trying to get through that drains by putting a tiny little stent. In fact, the stent is the smallest FDA-approved foreign body that exists. It is so tiny that if you put it on your finger, you probably can't even see where it is. And it goes into the drainage system and help to keep it open. So the next question is, everything seems fine, but vision is declining. Why is that? So Again, this goes back to the point that I was making earlier. Glaucoma rarely causes noticeable vision changes. So when patients come in and they keep noticing vision is getting worse, we first need to make sure that everything else is looking fine, because very often it is not a glaucoma that's doing the vision deterioration. It is things like dry eyes, retinal problem, corneal problems. Those oftentimes will affect your central vision, meaning your vision that's straight ahead. Glaucoma, again, affects your side vision. So it is rare that it will affect what you see straight ahead, unless it is very severe and at the very end stage of it. And also, we need to realize that vision decline can occur simply from an aging eye. And I think I kind of talked about this point earlier, that the plumbing system in the eyes, they're basically as old as you are, and they don't degenerate. And so the interventions are meant to slow down their decline and not to restore their function. This plot here is actually from a paper published from UCLA about 5-6 years ago. It shows that on the top here, you see the slow progressor. That basically refers to people who don't really have glaucoma. And you can see from birth to death, even if you don't have glaucoma, your visual function will decline. Now, if you have glaucoma, you decline much faster. You're one of these solid lines. You can drop down a lot faster if nothing is being done. Or if we intervene early, then we can try to slow down the decline of the visual function. So that's really a key point to understand. Yes, the vision may decline, but if you don't have any treatments, if you're not on the eye drops, you may decline even faster. So what about supplements? There is no direct effects from any diet, supplements, nutraceuticals in preventing glaucoma progression or preventing glaucoma from happening. However, there was a very recent publication in a very reputable journal about 2 years ago, shows that meditation and positive mindsets have almost the same effect in lowering the eye pressure as one single class of medication. So I always tell patients, healthy mind, healthy living leads to a happier brain and healthier cardiovascular system, which always helps, because if you have healthy vessels, the blood vessels goes everywhere, including your optic nerve, including your eyes. They will then bring nutrients to your optic nerves and make sure that they stay very well nourished. So just healthy living, positive thinking, that's something that's still within your control, and that's something that you can certainly optimize. So while there is no direct link between any of the supplements and glaucoma progression, I do firmly believe that if you live healthy, eat healthy, exercise, that at least you're optimizing the variables that are still somewhat within your control. Am I going to be blind? I get asked that question a lot. I would say most likely no, but theoretically, yes, that's possible. So there have been ample of studies looking into exactly what is the rate of people going blind. So the most recent statistics is that it is very low, somewhere a little less than 0.1%. And just to put things in perspective, the odds of you dying in a vehicle crash, that's actually 0.97%. So almost 9 times higher. You're 9 times more likely going to die in a motor vehicle accident than you go blind from the glaucoma. And I believe that rate for going blind is going to continue to get lower as we improve on medical and surgical treatments. So the simple answer is no. Especially if you do your medications, have your regular follow-ups, the chance of that happening is almost just statistically non-significant. So what happened to, some people may ask, what about those 0.1% people that still go blind? Well, that gets back to the point I was making earlier. Eye pressure is not the only cause of glaucoma. So while we can take care of the pressure part, we simply don't have any effective means of taking care of non-pressure related causes. And also, some people actually lose their sight from glaucoma surgeries, which, as we know, it carries a significant risk trying to tinker the pressure system in the eye. So people do have can develop problem from surgeries. And also, some people just have late diagnosis. They get diagnosed very late. The nerve is already very damaged and very susceptible to even to just be barely alive type of a picture. So that certainly is possible. However, it's important to keep in mind that while very low percentage of people eventually go blind, 10% of the patients with glaucoma will have some degree of vision impairment. And that's usually some degree of peripheral vision loss. Sometimes the peripheral vision loss is so obvious that the patients are aware of it and they need to start turning their head and look around. And that can be an issue, especially when it comes to driving or walking on the street. You don't see what's in front of you, for example, or on the ground, you don't see a little stones or something in front of you. You can trip and you can fall. Now, question number 9, can glaucoma worsen even with a very well-controlled eye pressure? Again, yes, very rarely. For a reason I mentioned several times, there are pressure-independent causes. And then also, some other conditions in the eye can also mimic glaucoma, such as a small stroke affecting the blood vessels supplying the optic nerve. Migraine sometimes can mimic that too. And also, experiments suggest that optic nerve function can continue to deteriorate even after we reverse and normalize the pressure. I tend to think of that as, once the water pipe is broken, the water is out. Even if you fix the pipe, the water is still out. You still have to deal with the mess that's out there. So fixing the pipe is one thing. You don't really just stop the damage there. There's all the water that's coming out. So that's just one analogy that I often use. But that doesn't mean that we shouldn't do anything, because if we don't do anything, then the consequence is even worse. So that doing something, meaning fixing the pipe. And in glaucoma, at least we should lower the pressure. It doesn't mean that the damage will just stop right there, but the damage will always be worse if we don't do anything about it. Now, final question, what's coming up in the horizon? Well, I kind of make this list in terms of sort of chronological order. I think the next wave that's coming in is the sustained drug delivery. Intraocular, which there is currently one already just very recently approved by the FDA. It involves injection of an implant that slowly releases medication into the eye, so you don't have to be doing the eye drops. And also contact lens-based delivery of the drug, or punctal plugs. So these are ways to kind of reduce the inconvenience of putting drops on your eye every day. And new classes of glaucoma medications may emerge with entirely different pharmacological targets. That's always in the work. Also, objective field analyzer. Many of you who have glaucoma here listening, you probably, I can guess that you don't like taking the peripheral vision test. I'm totally with you on that. Peripheral vision test it's challenging. You never feel like if you're hitting the right answer, if you're being consistent or not, and you sit there and you stare straight ahead, most patients can fall asleep or just feeling frustrated. So objective field analyzer is something that is going to be very revolutionary. You just look into a little goggle-like device. You don't need to click any buttons. It uses your pupil response as a way to test your visual function. So we're actually very excited to be, I'm going to be one of the principal investigators on the clinical trial testing the objective field analyzer. We were originally going to start that clinical trial enrollment this year, but because of the COVID, the company that's making the analyzer has some supplier issues. So that may not happen until sometime next year. So stay tuned. And of course, artificial intelligence with machine and deep learning, that's always making a major impact on many corners of medicine. My laboratory group is working on that too. High resolution live imaging of the drainage system to help guide and target glaucoma surgery. That's also another interest in my laboratory. And also smarter glaucoma implants that are very small and that can regulate pressure by itself. That's also coming up in the horizon. And finally, stem cells and optic nerve regeneration. Although I think we're at least several years away from that. That's a very complicated challenge to solve, with many sort of smaller challenges that need to be overcome first. All right, I know I kind of run a little over time, but thank you very much for your attention, and I'll take a look at your questions and answer them after Dr. Wade's talk.
That's perfect. Thank you, Dr. Lin. All right, Dr. Wade. Let me go ahead and pull you up. And we'll be seeing Dr. Wade in just a second.
Hey.
Hi.
Hi there. Can you see my slides?
Is it a big eyeball?
That's right. Okay.
Perfect. All right.
Good. Well, I am just pleased to be here with Dr. Lin. Dr. Lin is one of the smartest people that I know. Anyone who goes to Stanford, Harvard, and MIT, and then all the while remains one of the kindest and most humble people you've met, is a really special person. So it was a real treat to hear him and his talk. So my name is Matt Wade. I am a husband, I'm a father, and I'm also a surgeon. And I'm excited to share some time with you talking about what I like to do at work, which is cataract surgery and treating people who have cataracts. Now, one thing that Ken said that I really liked was when someone has glaucoma, they don't all have the same target pressure. Everyone's individual. And I think the same can be said about cataract surgery. Everyone's situation, everyone's eye is different. So what works for one person definitely doesn't work or may not work for someone else. And I think that's an important thing to keep in mind as we go through some questions today. So again, everyone's an individual. It's point number one. I mean, I think about my kids. I have 3 kids, a daughter and 2 sons. I wouldn't buy them the same birthday present because they have different wants, different needs. They're individuals. And the second thing about cataract surgery is it's scary. I think there's a lot of anxiety involving surgery of any type, and especially when it comes to our eyes. This hit home for me. You know, I'm a surgeon, like I said, I do surgery. I'm very comfortable with surgery. But a few years ago, I tore something in my hip and I needed to have it repaired. And this comfortable surgeon all of a sudden became very anxious and aware of what I didn't know and what I didn't understand about my hip and what was going on. So I have a lot of empathy for everyone going through this process. So I'm hopeful. I hope we can go through some questions. Type your questions up, or we can ask them at the end. I can't answer HIPAA-related questions, meaning you can't ask me very personal things, but general medical questions we can go over. And so go ahead and type those in the chat. And while you're kind of getting your questions together, there's a few questions that I want to go over, and I also want to get kind of a lay of the land. So I have a few slides just talking about what cataracts are and what they do. And I have to give a special thanks to Melissa Wang, who is a future doctor, currently a medical student and an artist who hand drew many of the images that you'll see in my slides today. So let's see if I can go through these. So this first slide here, if you look in the pupil, you have the colored part of the eye, the green part in this particular case, and in the middle there's just a black area, and that's clear. You don't see any cloudiness, and that's how we're born. We're born with a lens that sits right behind the iris that's clear, and not only is it clear, but it can change shape, and that's why if you're lucky enough to have good vision, meaning you can see well at distance, when you're young, you don't need reading glasses. You just hold something up there and the lens changes shape, and that change in shape causes more power and things up close become in focus. And unfortunately, when we hit our 40s, and I'm starting to experience this, unfortunately, you would think as a surgeon I'd be immune to this, but not really. We have to start holding things further out, and we can't see up close quite as well. And that's really the first sign of a cataract. It's the first sign of lens dysfunction. That lens loses its elasticity and its ability to change shape, and we don't have as much range as we used to have. As time goes on, the lens ages even more, it starts to change color, and it becomes cloudy. And we can see in these next couple of slides, you can see some cloudiness start to show up in this lens. You can see it's becoming more cloudy, and eventually the lens will become fully white and you won't be able to see through it. Now, unlike glaucoma, what Dr. Lin talked about, glaucoma, unfortunately, once glaucoma has occurred, we can't reverse the damage that's been done. But thankfully with cataracts, we do have a way of undoing what's happened here, and that's by removing the lens and replacing it with a clear plastic permanent lens that will last the rest of our life. But before we go too much into that, I just want to show you kind of some side angles of this eye. Imagine we were inside the eye and we could see what was happening, and we can see the importance of this lens. So this is a general makeup of the eye. The front window of the eye, that clear window on the left, is the cornea. Very thin, but very important. We have the iris, which really, it functions as a shutter, right? It opens, it closes, and it allows just the right amount of light in for the situation that we're in. If we're in a dark environment, it opens wide to let more light in. If it's really bright, it closes and doesn't let quite as much light in. And then behind the iris, that's where the lens sits, and that's what becomes eventually the cataract. Now, all these parts really in the front of the eye are all designed and they're all geared towards focusing light. The cornea bends the light. The iris blocks out only the light that you want to see, and the lens also bends light. And everything is so that you can get a clear image on the retina, because the retina, that image is taken by the retina, which the retina is really a transducer. It takes that image, it takes light, changes it to an electrical symbol or signal, and then sends that to the brain. And that is how we see. So you're out, it's a beautiful day, you see a leaf on a tree, and your optical system in the eye takes that image that you see, places it on the retina, and the retina takes it to your brain, and you see a leaf. But as the cataract progresses, that lens isn't clear anymore. So that leaf that you're seeing, that image is scattered, it's blurry, it's not as sharp and as in focus as it used to be. And many people have many different types of symptoms from this, but one common one is that at night, they're getting a lot more glare and halos around oncoming traffic lights. You can see on this image in the left, that glare, that halo, that mist around the lights. A lot of that has to do with this same image that I showed you here about the leaf. The light is being scattered and things are not as crisp and as clear as they used to be. Okay, so what do we do about this? Like I said, we take out the cataract lens and we put in a new lens. We'll walk you through some of the basic steps of this surgery. So a small incision is made through the cornea. The cornea doesn't have blood vessels, and so oftentimes, most times, there's hardly any bleeding with cataract surgery. Sometimes you'll see a little redness to the eye, to the white part of the eye, but there's typically not much bleeding that we're concerned with, which helps me answer one question that people often have, which is, do I need to stop my blood thinners? I'm on aspirin, I'm on Plavix, I'm on Coumadin. Do I have to stop? And the answer is, for most cataract surgeries, no, you don't, because we're going through the clear cornea, which doesn't have a blood supply. So then we make an opening. This cataract, that lens, has a support structure that it sits in. And we make a small opening in the front. You can see that circular opening. And then we use an ultrasound probe that breaks the lens up into small little pieces. Sometimes people ask me, can I have my cataract when you're done? And I say, I really can't give it to you because it's in a million little pieces. And that's how we get it out through such a small incision. But this is the probe. It irrigates, puts fluid into the eye, and then removes through suction and ultrasound those small little pieces. And there you go. The cataract is gone. We're left with that support structure that we started with that was holding your cataract. And now we have a space. We have space that we can put a new lens, and that's exactly what we do. And that lens is folded up. It goes through an injector into that space, unfolds, and that lens stays there, like I said, for the rest of your life. Now, some people say, well, really, is it really going to last the rest of my life? And I say, you know, the youngest patient that I've done cataract surgery on was just a few months old. And it was a baby who was born with cataracts. And I definitely anticipate that the lens will last that child's lifetime. And therefore, you know, many of us are much older than that, and this lens can last the rest of our lives as well. So after surgery, which, by the way, the surgery takes about 10, 15, sometimes 20 minutes, you go home and you have a clear shield over your eye. You put drops in for a few weeks. You're asked not to rub your eye or to go swimming right away or to lift anything heavy right away. And your eye actually heals quite quickly. Every once in a while, we need to put a small little stitch or suture to keep the incisions closed for a day or two. But the eye is quite capable of healing well and seeing really right away. It's not going to be clear right away, but you can use the eye even that same day of surgery. Surgeries are outpatient, so you go home. the same day of surgery. We typically do one eye at a time, although in some institutions, they are starting the idea of doing 2 eyes at once. Currently at UCI, we just like to do 1 eye at a time, come back the following week, and take care of the other eye. Okay, so that's the overview. We have some bearings, and I'll get started with a few questions that I typically think of, which the first is, should I have cataract surgery? And this is a very interesting question. I have a lot of patients who come in, they'll say, look, I was diagnosed with cataracts, you know, so-and-so said I needed to have them out. And my first question back to the patient is, are you bothered? Are your cataracts bothering your vision? And if the answer is no, or if the answer is you can get a new pair of glasses and then your vision is better, then my answer in return is, let's just wait. If it's not bothering you, there's no reason to go ahead. Now there is a caveat, as Ken said, that the real world is not always really simple. There are a few instances where the doctor will say, where I will say, we really need to take care of this right now for glaucoma reasons, for other reasons. But by and large, if the cataract is not bothering you, then it's not bothering me, and we can just wait. So the second question is, you know, it's COVID, we're in the pandemic. Should I really be having cataract surgery? Is it safe to do something like this? Excuse me. When COVID first started, we shut down all elective surgeries, and then gradually we started up again. And I mentioned earlier, I go home to my kids and my wife. I don't want to take anything home to them, and I don't want anything untoward to happen to my patients. And I have to say that the precautions we take in general, and specifically in the operating room, I'm very comfortable with these precautions and in terms of mitigating the risk as much as possible. Frankly, it's probably the cleanest place you will ever be during COVID is in the operating room. Much cleaner than any grocery store you've ever been to. Anyone coming in, any patient going there actually has to have a COVID test a day or two beforehand, so we can tell if they have COVID, and we keep everything extremely clean. So in my opinion, if the cataracts are bothering you and it's causing difficulty with driving, reading, other things in your life, I wouldn't hesitate to make an appointment with your doctor to discuss going forward. But again, everything is individual. You have to discuss your risk factors, your concerns with your doctor. Okay. So at this point, I'd like to take a few questions. I have other things that I want to talk. Actually, sorry, before we do that, I have one other thing I want to talk about. So probably the bulk of any conversation about cataract surgery, after we've decided, you know, yes, I do want to go ahead with cataract surgery, has to do with lens options. So let's talk a little bit about what those are. So we take the cataract lens out, we put a new lens in its place, and these are our options. We can put a lens in, it's called a monofocal lens, and that means it has one focus. And you may say, well, how many different areas of focus can we have? And in our daily life, we typically have 3. We have distance, which is far away, intermediate, which is basically arm's length, or think of it as your computer screen, and then near, which is up close for reading. So distance is a very common goal for people. And with a monofocal lens, if we focus at distance, that means the computer screen and up close are going to be somewhat blurry, but you have good vision at distance. And like I said, this is a common goal that people have. So we can also just pick a different lens power. And you may say, how do you know what power to pick? Say I want to read up close. How do you know what power lens to put in my eye? And where do these lenses come from? Well, when you have cataract surgery, beforehand, when you're in clinic, you have a lot of tests. You have scans that measure the length of your eye, the curvature of your cornea, all sorts of parameters of your eye. And we use those numbers along with formulas to predict what power lens you'll need. Now notice I said predict. There is a little bit of a bell curve there, but the formulas are very good, and they allow us to determine what lens power you need. And if you were to come to our surgery center, you would see walls and walls of lenses, just every type of power. And that's how we have we have the one that's going to work for you. So if we aim up close, we can see well to read. We don't see as well at intermediate, we don't see as well at distance unless we put glasses on. When we put glasses on, the other distances that are not covered by this particular monofocal lens come into view. So we've talked about distance and near. The other option is intermediate. And then there are lenses that split the light. Now this, I've said multifocal lens here, but there really is a whole category of lenses here. Multifocal lenses, extended depth of focus lenses, coming down the pipeline, small aperture lenses. There are all sorts of ways of getting more range. So instead of being limited to just distance or intermediate or near, you want more range, and these type of lenses can do that. Sometimes there's drawbacks. One of the drawbacks is cost. Multifocal lenses are not covered by your insurance. They're usually a few $1,000s per eye. And in exchange for that, they give you more functionality, more range. They can also cause a little more glare and halos at night. So back to the very first point I had with this discussion, which is it's very much an individual discussion. It really needs to happen between you and your surgeon, and you, as the more you can express what your goals, your hopes, your desires are, and the more that your surgeon has a chance to see what else is going on in your eye. For instance, if someone has advanced glaucoma, they're not a good candidate for a multifocal lens. So the exam is very important, the testing is very important, and having a frank discussion about the pros and cons is very important. Now I say pros and cons. A phrase I like to use a lot is that during cataract surgery and in picking a lens, we're really managing compromise. We don't have the perfect lens that has no downsides and no cost and just gives you everything you want. We do have great technology though, and if we can manage the compromises in such a way that makes you happy, then we've had a successful result. And the other phrase that I say a lot actually is what is your relationship with your glasses? Because that determines if you really hate glasses and you and your glasses don't get along, you may be a better candidate for something like this. If you don't mind glasses, then we can swing back towards the monofocal lenses we talked about earlier. And I can't harp on this enough. Because your friend got a lens, that may not be a good lens for you. And that cuts both ways. They may not be happy with the lens, but it may be something good for you and vice versa. So please be willing to keep an open mind and also to have that frank discussion with your physician. So one other kind of thing that we work with is setting the eyes up for different distances. Now, there's such a thing called full monovision, where one eye is distance and one eye is way up close. If you haven't worn that before with contacts, you're not going to like that. So we won't employ that, but there's also such a thing as mini monovision, where the eyes, maybe one is distance and one is intermediate, or one is intermediate, one is near. That can be a very effective solution and can give you more range, more ability to maybe check your phone, which is such an important thing these days. So this is something also to discuss with your physician. Now, if your eyes have other things going on, like glaucoma or macular degeneration, this may not be as good of an idea, because you want each eye kind of off on its own, alone, without the help of its fellow eye, if the eye and the vision is compromised in any way. Okay, so that's a discussion about lens types, and we have two more things to cover. One is astigmatism, and astigmatism is so important. I actually wear these glasses because of astigmatism. I can see really well without them, but not as sharp. I definitely see more clearly when I fix my astigmatism, either with glasses, or we can fix it during surgery using a laser or a lens, as I'll show you. But what is astigmatism? Astigmatism basically means that the front cornea, the front surface of your eye, that first surface that light hits when it comes into your eye, instead of being round like a basketball, is more like an American football. It's flat in one axis and it's steep in the other axis, and the light gets jumbled up because of it. And in my opinion, there's no downside to treating astigmatism. It does cost extra, but it improves your vision at all distances, distance, intermediate, and near. And it really gives you a better visual outcome. If your astigmatism level is very high, you may even see better. You know, you can wear glasses, but the glasses will have a lot of distortion on the outside. So in my opinion, this is a very good thing to do if funds permit it. And some people, they have low amounts of astigmatism. They don't have to worry about it. Some people, they're going to wear their glasses either way. They may not have to worry about it, but definitely something to discuss with your physician. So this is an image of a laser making some relaxing incisions in the cornea to change and improve the shape of the cornea and to treat the astigmatism. This is called laser cataract surgery. It's not covered by insurance. It's not required. It is an add-on or upgrade you can do to help improve the astigmatism that you have in the cornea. And this is an image of a lens, just a drawing of a lens, that has marks on it. And those marks indicate that this lens is an astigmatism correcting lens. So we can move those marks around to where they line up with the astigmatism you have in your eye, and we can help negate the astigmatism you have. And this is one of my favorite lenses to put in because of the benefits that it has. Okay, time is running short. So I have one more topic. I don't know how many questions we'll get to, but we'll try our best at the end here. But this last topic is so important. I can't stress it enough. And it sounds really innocuous. It sounds like it's not a big deal. And that's dry eye. Now, rarely do people just walk in and say, I have dry eye. They walk in and say, my eyes are burning, my eyes are itchy, my eyes get tired, my eyes are blurry, and sometimes they're clear and I blink, you know, or they're blurry and I blink and then they get more clear. And, you know, when we talked about the optics of the eye and how light comes in and it bends at the cornea and then it bends again at the lens, it's important to know that 2/3 of that bending power is really the cornea, that front surface. The lens only contributes 1/3 of that power. So when the front surface of the eye becomes dry and that surface becomes rough, that's the most important optical surface of the eye. And that becomes rough, your light is going to scatter. You can have glare and halos, decreased vision, pain, irritation, redness, itchiness, the whole works. So what does this have to do with cataract surgery? Well, one, the more dry your surface is, it's hard for us to get good measurements to pick a lens power for you. So the more you can use artificial tears before surgery, before measurements, the better set of measurements we're going to get. The second thing is dryness only gets worse with time. It only gets worse with time. So I look my patients in the eye and say, over the rest of your life, your dryness will get worse. And it's kind of like high blood pressure. We can't cure it, but we can help manage it. We can do things to help decrease the dryness. And temporarily, actually, after cataract surgery, your eye will be a little more sensitive. For a few months, it'll be more sensitive. You had surgery, we touched the eye, you're using drops. Those drops have preservatives, and those can irritate the eye. All these things can cause a bit of a decrease in vision or a waxing and waning of vision. So please take your eye doctor serious when they ask you to treat your dry eye. Do consider using more lubricants, and do pay attention to vision that waxes and wanes, and understand that that may not be from the cataract, but that may be from the dryness that's on the surface of your eye. Now, why is this increasing? It is increasing, by the way. It's increasing because of screen time. It's increasing because of air conditioning, because of pollution, all sorts of things. We actually did a study recently where we went to Google and we pulled data from Google. You can borrow data from Google. And we looked at all the terms that people search dry eye by. Anything that has to do with dry eye. And if you normalize those terms based on other searches that people do, we saw that over the last 10 years, the searches, the interest in asking Google about dry eye went up 150%, and is slated to continue to rise like that over the next 5 to 10 years. So, and interestingly, the top state for that is California, based on that data. So there's just a lot going on with the surface of our eyes. They have a lot of stress, and the best thing we can do for them is keep them lubricated. So there you have it. I hope that you understand a little bit more about cataract surgery. Maybe anxiety is a little bit less, and this has been really enjoyable for me. And I will stop sharing my screen and open up for any questions.
All right. Thank you, guys. I think we do have, well, I know we have loads of questions in chat. Dana?
Yeah, so I can go back to the questions from Dr. Lynn's presentation. Someone asked, what is considered to be very low blood pressure, Dr. Lynn?
Oh, sorry.
Yes, I have been dying to say something. I'm just kidding. Actually, Dana and Alex, if you guys don't mind, I already kind of looked through the questions, and so I have a list here. So maybe I'll go through those questions while Dr. Wade may have a chance to look at the cataract portions, and then that way I'll just kind of answer the glaucoma parts, and then I can pass the baton to Dr. Wade if that works out. If that works.
Yeah, so any cataract questions we'll voice to Dr. Wade. And then Dr. Lynn, you want to do
I pretty much have I can take care of the glaucoma part and
okay.
Yeah. So the first question was, what is a low blood pressure? I assume the question is more about what is considered a blood pressure that is low enough that we're starting to suspect that being a possible cause for glaucoma progression. That's a great question. In general, if your systolic is less than 90, then and your diastolic is less than 40 or so, we start to get worried. It's very rare to see people with that kind of blood pressure, but we do see them from time to time. It's one thing if you're a professional athlete and you run a very low blood pressure, but if you're not a professional athlete and you're running a systolic constantly in a 2-digit zone, then the light bulb's starting to go on. So the next question is somebody asked me to explain a little in greater details about nasal spray and steroid and glaucoma. Great question. So I talked about how steroid can cause glaucoma by raising the eye pressure. So let me go a little bit into detail on that. So exactly what steroid does is that it actually makes your drainage system more resistant. So and specifically, it causes the internal drainage system within the eye to start secreting more collagen. All the empty space within that drain starting to get filled up with these collagenous kind of blobby-like material when people start using steroid. It does not happen to every individual, but it just so happened that as many as 30% of the populations are to some extent susceptible to the effect of steroid. And that effect is very bimodal. Kids can show a very dramatic steroid response. Also, those who are above the age of 75 tend to also show a little more dramatic steroid response. But the group that is most susceptible to steroid are generally kids, followed by those who are 75 and above. But pretty much in general, as a general population, I think about studies kind of differ in the details, but we mostly think that about 20 to 40% of the people are susceptible to that. So when your ENT doctor recommends that you do Flonase, I know Justin Verlander is putting a commercial, oh, how much it helps, and that's great. Flonase does do wonder, especially if you have chronic sinusitis. But just be aware that of all the ways that you can put steroid in your body, putting steroid into your nose is the #1 most likely way to raise the eye pressure. And that is thought to be because the steroid gets deposited into your nose. There is a connection between the nose and your eyelid called the nasolacrimal duct. That's actually how we drain the tears into your nose. That's why when you cry, you get runny nose too, because that channel is open. So if you spray nasal spray, that spray releases the medication under some localized high pressure, it goes straight up and then can basically make itself available to the eye. Now, that doesn't mean that you have to just panic and run and need to get your pressure checked. But if you already have glaucoma, that is something to be aware of. And what I tell my patients is, if you are just using Flonase or any of these steroid medications into the nose, occasionally then just let me know. If you're gonna start doing that on a daily basis, I will check your pressure about 1 to 2 weeks after to make sure your pressure isn't rising up to the dangerous high point. And for the most part, I may see a couple points of increase, which is inconsequential, but it is important to at least check after you start using it regularly. If you're using it very infrequently, that generally is an okay thing to do. And then you may wonder about, what about steroid shots to the joint, steroid pills? As long as it's not a chronic thing, meaning you're taking it more than 3 weeks and then you've been taking it for 3 months nonstop, that's really not too much of of important consequence. Steroid shots to the muscles or the joint, that usually plays a very insignificant role in raising the eye pressure. Next question, we have somebody who is 81 years young with glaucoma, states that eye drops irritate the eyes. How long do I have before I go completely blind? Oh, let's not be too pessimistic. You should be able to enjoy your vision for the rest of your life. That is what we're striving here for. I would say in general, there is no quick way to tell, quote unquote, how much time you have before something goes out. That, for the most part, it depends on how high your pressure is, how much damage has occurred. And from those two, we can have some kind of an estimate. But before losing hope on just say, all these drops irritate me, we first need to figure out exactly what have you tried and what have you not tried. There are multiple medications. Yes, to some extent, they can all irritate the eye. But if the irritation lasts more than 3 to 5 minutes, then we need to look more into that. Otherwise, if it's just when you put the eyes and it burns and stings the eye, that unfortunately is going to be true for any kind of a medication you pour on the eye. But I think that notwithstanding, the benefit still outweigh the risk. Of course, a small percentage of patients, they may be allergic to the preservatives that's in the eye drop. So for my patients who react badly to multiple classes of medications, I will then put them on preservative-free eye drops. There are such eye drops that exist out there, even though at a slightly higher cost. That is something that I will consider for my patients as well. Of course, there's also laser treatment that is very low risk. Takes about 5 minutes to do in the clinic. For some of my patients who just absolutely cannot tolerate any drops, I can still lower their pressure through laser. So that's for that question. And can having dry eye affect glaucoma? No, but having dry eyes can make can make that burning sensation with the eye drops even worse. As Dr. Wade so eloquently summarized, dry eye is very common. Dry eyes can make you have intermittent blurry vision, but dry eyes can also make your eyes very irritated and sensitive to anything that you put onto it. Even winds can make your eyes very irritated because the eye surface is dry. So if you have dry eyes, the dry eye itself is not going to cause glaucoma, but the dry eyes can make it just even more difficult for you to want to put that drops to treat glaucoma, which can then secondarily lead to worsening of glaucoma. Now, I have another question about checking pressure in a post-LASIK eye. Now, this is eyes that have undergone LASIK, and the audience was told that the pressure checking can be quote-unquote false. Now, what this is referring to is just that most pressure checking mechanisms make some basic physical assumptions about the thickness and the biophysical profile of the cornea. If you have LASIK, that thickness and the biophysical profile of the cornea is altered in such a way that when we check your eye pressure, it may be a little of an underestimation of your true pressure. But that is not an issue at all. In fact, I would challenge that that doesn't make the measurement false. What we do in those cases is that we simply just check the pressure using the same measurements over time. Again, it's like having a measuring tape that's not exactly well calibrated. The 1 inch is slightly wider than what a true 1 inch is. But if you always check the height using this not so accurate tape, and if the height is not changing, then your measurement shouldn't change at all. However, if you use this inaccurate tape, and yet the height seems to be changing over time, then we have a concern. So that's the same scenario here, where we're not so obsessed with getting that absolute true pressure value. We are more concerned about changes over time. So the degree of underestimation or overestimation stays constant over time. So if you always check it with the same method and preferably by the same provider, then we know that we have control all the variables. And so if there is a change, then you can safely conclude that that change is because of your pressure really is going up or down or whatever the case is. Now, final question. An audience said that it was told to have acute angle due to drusen. Now, this is a little confusing. Drusen typically is referring to these yellow spots in the back of the eye, suggested of macular degeneration, which is entirely a different class of diagnosis. But this patient also have a procedure done to make a hole. So wanted to know about what exactly, can I comment more on this condition? So with the limited information that you provided, I am thinking that you may have had something called narrow angle. Now, narrow angle, let me just kind of give you the big picture in the next 1 minute, and then I'll shut up. Your eye is divided into the front chamber and the back chamber. What separates the front to the back is the lens that Dr. Wei has so many beautiful illustrations to show. So everything in front of the lens is called the front chamber. Now the front chamber is important because that's where the aqueous fluid leaves the eye. So, and it leaves the eye in that little corner of the front chamber. We want to make sure that corner stays open. So in people with narrow angle, that little angle where the fluid drains becomes very narrow. And if it is so narrow that it becomes possible that at one point you're going to completely lose your front chamber and the front chamber will collapse and no fluid will leave your eye, and you get into this catastrophic situation called acute angle closure, which we see at UCI's emergency room almost once or twice a month. And that can occur just very suddenly, give you a lot of pain. You can throw up. That's a condition that we certainly want to catch before it happens. So people who are born with a smaller eye or who have a pretty big lens that pushes that makes the front chamber narrow, we always recommend them to have a laser procedure that involves making a little hole on the iris. I won't go into the physics of how that all works, but what it does is it helps to deepen up the front chamber a little bit, and it works almost 90% of the time. The rest of the 10% that doesn't work, then we need to really go in, and that's where excellent cataract surgeon like Dr. Wei will then go in and take out that lens, because the ultimate problem is that lens. As we age, the lens gets bigger, and as it gets bigger, it pushes on the front chamber and making the front chamber shallower and shallower. So while the hole works most of the time, there may come a time in the future where it still continues to shallow out, and that's why usually for those patients, they need to be seen every 6 months or so. So I'll now pass the baton to Dr. Wei to answer some of the cataract questions.
Okay, can you hear me?
Yes.
Okay, great. So thanks for sticking around past the time here, and I'll try to go through some of these questions. I just want to point one thing out though. So I'm actually, in addition to a cataract specialist, I'm a cornea specialist, and same with Dr. Lin. So Dr. Lin and I are both cataract specialists, and we both treat cataracts the same way. We both take care of all these issues. He has the added training in glaucoma, and I have a little added training in cornea. I just wanted to point that out. So if anyone needs cataract surgery, Dr. Lin is an excellent choice for that. So Becky asked a question about what are the risks of cataract surgery for patients who are very nearsighted. That's a great question. So when the eye is very nearsighted, it actually means typically, not always, but typically that the eye is longer. And you can imagine that the retina, which is kind of like wallpaper inside of a room. So if you have a bigger room, that wallpaper is stretched a little more thin, and it's more likely to have a tear or detachment in general, even without cataract surgery. But with the surgery, you're at a slightly higher risk. So in patients who have high myopia or high nearsightedness like that, I always recommend that they see a retina specialist first. They can do a detailed exam, see if there's any laser or other work that needs to be done to decrease that risk for retinal tear detachment. That's a great question. From Trisha, by the way, Trisha, thank you. Your daughter has taught me a lot, so I really appreciate that, Trisha. Trisha asked if the incision is going to hurt after cataract surgery. And you would think that cataract surgery would just be so painful and uncomfortable, and it's really shocking to me and surprising that it's not the case. Patients typically say For the first day, they felt like there was a grain of sand in their eye or an eyelash, but starting the next day, the pain is typically fairly low. Now, that's not always. It's definitely more painful when patients have a lot of dryness to start with, but in general, the incision is not painful. Compare that to someone who has a corneal ulcer, and that is a defect in the front surface where all those nerve endings that doesn't have a chance to heal nicely like an incision, and that can be extremely painful. So it's very different than that. Jill asked about the risk of retinal tear in general after cataract surgery. That's risk is about 0.4%. Like I mentioned, in the patients who are high risk, we can mitigate that to some extent by having them see a retina specialist and check for anything before and also right after to make sure we can head off any small tears before they become bigger. Could I compare, let's see, Xing Su asked, could I compare laser cataract surgery and conventional? So yeah, great question. When laser cataract surgery came out, we thought it was going to change everything, and in some ways it has, and in some ways it hasn't. In terms of overall safety, it's been shown by studies that it's not necessarily any safer than regular conventional cataract surgery. There are a few caveats, which your doctor can talk to you about, but what it really is good at is treating astigmatism, and that's really what you're paying for when you have laser cataract surgery is that the ability of that laser to reshape gently the cornea in such a way that you have less astigmatism at the end of surgery. So to me, that's the main reason to have laser cataract surgery. Becky asked if there's any vitamins, supplements, or diets that can be helpful with cataracts. Not to my knowledge. Now, I will say there are supplements if you have macular degeneration. There are even supplements that you can take like omega-3 fatty acids to help with dry eye disease. But we don't really know how to stop or get rid of cataracts with supplements in general. Kara H asked if it's possible to have two different types of lenses, and the answer is yes. And in fact, you may, even if you ask for monofocal distance in both eyes, because the eyes are slightly different power, you may get slightly different powered lenses in each eye anyway. But if you have a goal of wanting one eye for near, one eye for distance, that's possible. You don't want to do full monovision unless you've tried it before, but a mini or micro monovision where you just offset the lenses slightly can provide more range and has pretty low risk. Catherine asked if dry eyes affect cataracts or glaucoma. Dry eyes, again, it's so ubiquitous. We're seeing it in kids. It's becoming just more and more of an issue. It affects your vision. So in that way, it does affect, your visual comfort and your ocular comfort and your visual quality after cataract surgery, and it can affect our ability to get measurements before cataract surgery. So Tricia asked, what are the best drops to use for dry eyes? Really what we like are preservative-free artificial tears, typically not a Visine or a Clear Eyes. Anything that has that get the red out component, we don't like that quite as much. But anything you can use to lubricate your eyes more, refresh, sustain, retain, blink, it's actually, I remember the first time, even as an eye doctor, going to the supermarket and looking at all the different types of dry eye drops, and there are so many, it's a little overwhelming. But if you look for ones that come in vials, those can be great. And you can buy those off-brand at Costco or other places. And if they're preservative-free, you really can't overdo it. You can use them every hour if you want to. Just one drop in each eye. The eye doesn't hold more than that at a time. But definitely the more you can lubricate, the better. So let's see what else. Oh, Robin asked, will cataract surgery improve eyesight deficit that is due to amblyopia? Great question. So amblyopia means that the connections between the eye and the brain have had trouble forming from whether it's from a cataract that someone was born with or needing to patch and not patching enough. That's amblyopia. And once you're into your 20s and 30s, we really can't fix the amblyopia per se. But what we found is if you do have amblyopia and you have a small cataract, maybe a cataract that wouldn't be as significant as someone else who didn't have amblyopia, that taking that small cataract out can improve things because of the deficit that's already there. those patients are typically more bothered by a small cataract than someone else. So I hope that is understood. You can't fix the amblyopia itself, but sometimes we have outsized effects from taking out even a small cataract. Can cataract surgery also correct floaters? This is from Diane. Diane, I'm so sorry. If you think back to that illustration, the cataract is in front of the gel, the vitreous gel. So unfortunately, when I take out the cataract and we clean that and put a clear lens in, you'll actually be able to see the floaters even better, which is not what you want, I know, but that's what's going on there. Song Mei Han asked, will artificial tear reduce, if I use artificial tears, is that going to reduce the number of tears that my eyes produce? That is a very great question. And I will say I don't have a good answer for that. As far as I would say no, but I could be wrong. What we do see though is when eyes are really dry, there can be a lot of inflammation. And inflammation is an important part of dry eye progression. So the more we can keep eyes lubricated, it's my understanding belief that actually will preserve those glands that produce lubrication on the surface by decreasing the overall inflammation. So I think it's actually better to take them than not, but it could be that we actually produce less. And I don't have an answer for you on that. Julie asked if you can have cataract surgery more than once. Also a great question. So we don't typically like to do surgery more than once. We can though, if there's a lens that's just definitely not working or it's not meeting your visual goals, we can take that lens out. There are a lot of nuances there, and it's not something that we jump into. We usually try to work around that. But this also brings up another thing, which is, do cataracts ever come back? And the answer is the cataract doesn't come back, but remember that support structure I talked about, that support structure that we put the new lens into, that support structure, your body can grow haze on that structure. And that's very common. In fact, I almost anticipate it. I tell patients to anticipate it. Your insurance company anticipates it. And roughly 30 to 50% of the time, you'll grow that haze and you'll require a little laser to polish that up. So cataracts don't come back, the haze does. We can remove lenses. It's not always a good idea. Definitely want to talk to your doctor about that. Have you heard of using lutein to keep eye from over tearing? You know, lutein can be helpful in retina health. I'm not sure about artificial tear wise. There are a lot of things that go into that. Tricia, I'll have to get back to you on that question. Great question. And BTA Fazoli asked, is it called secondary cataract? Yes. The term secondary cataract is actually kind of a misnomer, but that's what people use for this haze that grows or can develop after cataract surgery. And that is it. I again, thank you so much. This has been really fun for me. And one last thing, all the illustrations that I have and that I showed you, along with others, are available in a PDF that actually has a lot of information about cataract surgery. We will email that out to you. If you included your email and when you signed up, we'll email a copy of that to you so you can peruse that and have that for a reference.
I just want to add that I want to take maybe another 30 seconds to answer two more questions that have since emerged. One is a nasals. One person asked about nasal spray, whether that contributes to cataract. That is an excellent question. So not to a very significant degree at all. The thought behind that is cataract is more susceptible if you're taking systemic steroid, meaning oral, meaning injections, IV steroid type of pictures, because the lens obtains its nutrients from blood supply, and that's how you can actually increase cataract from increasing the blood circulation level of steroid. If you just put steroid into your nose, it makes it onto the eye surface. It affects the pressure, but it doesn't do the same and hardly does anything to the lens because the lens is more deeper inside of the eyeball. Excellent question. Now, another question about what is the long-term risk of cupping? So cupping is just a description. So cupping it refers to how the optic nerve is cupped rather than round. And that is one indication of a person possibly having glaucoma. So when a patient gets sent to me because of quote unquote cupping, then we need to do all the peripheral vision tests and the scan of the optic nerves to make sure, number one, does the person have or does not have glaucoma? Once we establish that this person does not have glaucoma and simply just have cupping, then it's almost like calling, again, I like to use height as an example. Then it's just like saying that this person is tall or short. But I will always have to bring the patient back at a separate time, maybe 6 months later, maybe 12 months later, to see if the height is changing. So we need to bring the person back and see if the cupping is becoming more cupped. Then we have a problem. Then we need to know what is going on. And sometimes it may not have anything to do with the pressure. It may be something in the brain, for example. So that's how we think of it. So the cupping by itself, it doesn't carry any long-term risk. Unless it is changing, then we need to know what is causing that cupping. In fact, just as an interesting kind of aside, is that if you were born premature, or if you had supplemental oxygen when you were born, which is quite common back in the before the 1970s, then chances are your nerves are probably a little cupped. There are studies after studies showing that you can just develop cupping of the nerve just from being born premature, and there's nothing wrong with that. That's just kind of how your optic nerve kind of mature. So they will always remain cupped, but they don't become more cupped. So as long as they are cupped, but they're not becoming more cupped, then you're fine. There is no long-term risk of anything. But if they're becoming more cupped, then we need to do all these subsequent workup. So I think that just about answers all the questions. But great talk, great to have everyone here. I'm happy to be here. If there's any other questions, I'm more than happy to stay to answer a couple more questions.
I think Elaine had a question about being African-American and risk for glaucoma. You want to take that, and I'll talk about the cataract part of that.
Oh, sure. Yes. So we know that African Americans and Hispanics are the two groups that are at higher risk for getting glaucoma. In fact, so much so that if you're African Americans or Hispanics, you should get a glaucoma screening exam once you hit the age 65. This is even in the absence of any any known family history of glaucoma. Now, if you're African American or Hispanics, and on top of that, you have a family history of glaucoma or somebody going blind for whatever reason, then I really highly recommend that you get a checkup. Because again, this is something that if we catch early, there are way more options to do something than if you catch it late. Great question.
Yeah, I'll just add to that while you may be at higher risk for glaucoma, you're not at high risk for cataracts. So the cataracts are pretty much evenly distributed. We're all going to get cataracts. It's kind of one of the benefits that we live longer. We all are going to get those. So, and thank you everyone for being here. Dr. Lin and I really appreciate this. And you know, we are just two people of many, many people. And I have to say, one of the things that I love about my job is the people I work with. I would and actually have sent my own mother to many of them, and I would trust them to a person. They're just fantastic people and fantastic surgeons and doctors. So that's been a privilege for me to work with these great people.
Absolutely. Likewise. All right. Have a good night, everyone.
All right, good night, everyone.